So yeah, as I was saying, um, cancer is certainly a concern for the general public, and I was going to go over how AI, through the use of CT radiomics and machine learning, might be able to help us better characterize lymph nodes in patients who have HPV positive oropharyngeal squamous cell carcinoma. And this is a preliminary work with our student Nicole Robinson here at the University of Chicago. So this is hot off the press, I guess you could say. So let me see. There we go. So just a little bit more background on this type of cancer. It's induced by human papilloma virus, and it affects the tonsil tissues in the throat. Um, and a lot of times, these cancers can spread to the lymph nodes of the neck. And the workup might entail performing, of course, imaging, whether it's CT, MRI, and/or PET, along with endoscopy and typically biopsy, sometimes even multiple biopsies of the various potentially affected sites. So being able to determine whether or not lymph nodes are affected through metastatic disease can have implications on the treatment of this cancer. And so we rely quite a bit on the use of imaging to make that determination, although it can be somewhat limited with specificities on the order of 0.6 to 0.7 or so. So yeah, once again, the presence of lymph node metastases is an important prognostic marker, and if they are present, the 5-year survival rate is cut by half. So yeah, the idea here is to see once again if we can formulate a quantitative method for more accurately distinguishing benign from malignant lymph nodes in these patients, of course. So we created a random forest radiomic model using pathology-proven cases of metastatic lymphadenopathy in these oropharyngeal cancer patients. And we used CT scans with contrast. So the hypothesis specifically was that certain radiomic features derived from the CT scans could help in characterizing the lymph node status with at least an area under the curve of 0.7. So we have quite a few patients in the last several years who've at our institution, over 200. But unfortunately, oftentimes the problem in medical research is that with the exclusion criteria, the number of cases whittles down to a relatively small number. So some patients did not have available pathology at our institution. A lot of these patients come from elsewhere, where they didn't have CT that was close enough to the time of the biopsy, for example, or if we weren't able to correlate the pathology results with the CT findings and so forth. So yeah, we end up with only about 40 patients, but surprisingly, we were able to glean some useful information from this. So here's an example of one of the CT scans that we used in the study. And so this patient had one of these oropharyngeal cancers, which is shown here in the throat, near the tongue base. And there was this lymph node here. Um, so oftentimes, just by looking at this, we can get a good sense that it's probably involved by metastatic disease. So I'm pretty confident that's the case here. But the fact that we do biopsy quite a few benign lymph nodes indicates that there is often some ambiguity. Oh, let me see. So moving on. So yeah, once again, we analyzed 40 cases. Um, and yeah, there were some slight variations in terms of the slice thickness of the images. I think that might depend on the particular scanner. Different manufacturers may have different protocols that are implemented. So that could be somewhat of a limitation. But anyway, yeah, we did manual slice by slice segmentation of the regions of interest using a 3D slicer. And basically, we had the two groups of lymph nodes labeled as positive or negative based on the pathology. And we extracted radiomic features using Radiomics software. And so we had a training set of 32 cases, so basically 80% of the sample, and the rest were used for testing as part of this random forest model, which basically uses decision trees based on a data set that's sampled randomly. And yeah, this is basically a summary of the workflow from the initial images to how segmentation was performed for the regions of interest, and feature extraction, where we could determine various characteristics of the lymph nodes, including morphology or shape and pixel intensity. So basically, CT simply measures the attenuation of X-rays by the different tissues and represents that characteristic in terms of grayscale levels. So we can get a range for a distribution of pixel values in the region of interest that's often with such a distribution, like as such. And then we can determine various statistical texture features, such as these, which here we have the 10 most salient features from our study. So shape was certainly an important characteristic, as well as the gray level characteristics. So yeah, the model performed quite well despite the rather small sample size, with an area under the curve of 0.9. And most importantly, there was a very high, or 100% specificity in this study. So that's very promising and particularly useful. The sensitivity is not as critical because we did include lymph nodes that were relatively sizable, at least 10 millimeters in short axis. So specificity is more important in this application because we the goal is to be as specific as possible for differentiating the benign versus malignant lymph nodes. Um, so obviously, we would have to further validate this using a larger sample size. So we'll continue to work on this, of course. But yeah, just to summarize once again for the clinical applications, um, the AI model can potentially elucidate features of the imaging that aren't necessarily easy to spot visually. Yeah, currently we render a mostly qualitative assessment of the scans, along with basic measurements such as the size of the lymph nodes. So this can, in the future, be used to maybe standardize how we evaluate these scans. Perhaps we can generate a score or probability for a malignancy, for example, by creating these so-called radiomic signatures. So yeah, the goal, of course, would be to minimize invasive procedures as a result and create more personalized treatments with the ultimate goal of better patient outcomes. So yeah, I touch upon some of the limitations, including the relatively small sample size. And of course, this is just a single institution study. So perhaps we can expand our future work to include additional cases from here and elsewhere, and to use maybe other artificial intelligence techniques, which may perform even better. So that was basically it, unless you have any questions or comments. But you can always email me. I guess with the hyperlink, it's hard to see.